Hello, pregnancy antenatal screening, 3 parts. This is the first part where we focus on what screening test do we offer routinely to pregnant women in South Australia as per the date of this month, January 2016. First, we offer a number of blood tests and a urine, mid-urine sample specimen at the first visit. Secondly, we offer screening for, in particular, searching for trisomia 21 and 18. Thirdly, we offer a morphology ultrasound scan looking at the anatomy of the fetus around 18 to 23 weeks. And around 27 to 28 weeks, we offer now a glucose tolerance test, an oral glucose tolerance test. And the last test we offer is a low vaginal swab, trying to determine whether the lady's vagina harbors group B streptococcus. I did produce a separate video about the antenatal screening for fetal and euploidy, and also a separate video about major fetal malformations, aberrations from the normal anatomy. Good to confirm that per definition, when we screen, we offer this screening test to women who don't any symptoms whatsoever. So they don't have any risk factors, they don't have pre-existing hypertension or diabetes. So that's important to realize. The sky is blue and we offer a screening test to find out if something is not right. It's important that we always explain to the woman what tests we offer and why, and what we would do with variations in the result. And of course the woman has the right to decline any screening tests. It's on a voluntary basis. If we look at the South Australian handheld record, or the so-called South Australian pregnancy record, when you look at page 4, we see the so-called antenatal schedule. And on the left-hand side we see roughly the visits which are scheduled, the initial visit, the visit at 20 weeks, 28 weeks, and so forth. And we see the frequency of visit offers is increasing, and that's based on the fact that we are particularly searching for preeclampsia and growth restriction. The other part of the page, you see an outline of various assessments, various questions, various tasks required, and in this part of the page we have also embedded the various screening tests offered. So for the non-experienced clinician, it's great. This part 4 is a great guide in how often to see a lady and what tests to offer and what questions to ask. Let's focus now on the antenatal investigations. That's the lowest part of part 4 in our handheld record. We see here a number of investigations and that's offered here. We offered the maternal screening. We offer screening for trisomia 21 and 18, separate video as discussed, and we offer the morphology screening for the fetus, major fetal malformations, separate video. So all these other tests are summarized here. Great overview, again, a good guide if this is not your routine when you're less experienced. Let's focus now on the first group of tests, serum tests, and urine tests we offer at the first visit. Blood group Rhesus, antibodies, a full blood count, the serum ferritin level, rubella titer, hepatitis B and C, antibodies, HIV, syphilis, and if the woman is at risk, we offer also to check her vitamin D levels. Important that you know what test to request, and as soon as you find out that the test is outside the normal range, for instance, the Rhesus is negative, Rhesus factor is negative, you find out there is a low serum ferritin or there's an anemia, there's a low vitamin D level, you find out there's an asymptomatic bladder infection, you find that there's gestational diabetes, or that the low vaginal swab is positive for GBS, that you know how to manage these variations of normal. For instance, if you find out that the Rhesus is negative, then we offer routinely at a gestational age of 28 and 40 weeks and post-delivery that we offer the injection of NTD. 28 and 34 weeks we give the full dose of 625 international units deeply intramuscularly, and after delivery we check the baby's Rhesus factor, and if the baby is Rhesus positive, again the same amount of NTD injected. This is to prevent sensitization of the maternal immune system if some red blood cells of the fetus have crossed through the placenta and entered the maternal circulation. So this is to prevent problems in the next pregnancy. Because of this program, we don't see active Rhesus antibodies in pregnancies hardly anymore in Australia. Of course, if a woman presents with symptoms such as bleeding, first or second trimester, or when we do procedures, then we have to be mindful of administering NTD prophylaxis as well. For instance, when a woman presents with threatening miscarriage in the first trimester, when we are managing an ectopic pregnancy, a molar pregnancy, DNC, termination of pregnancy, etc., we administer the 250 international units NTD. Please refer to my other video. I made 3 videos about early pregnancy. In the second and third trimester, every time when a woman presents with antepartum hemorrhage, regardless of the cause, if she presents with an abdominal trauma, or if we perform an extended cephalic version trying to turn the breech into a cephalic presentation, we administer NTD. And we perform as well a so-called Kalai-Hauer test. This test actually tries to find out if any fetal red blood cells have entered the maternal circulation, and if so, how many, and we can check whether the standard dose given is adequate, is sufficient. Another example of the screening could mean you find out that the lady has an iron deficiency or an iron deficiency anemia. This is quite common in pregnant women, and quite often the typical approach is that we grab a script pad and start prescribing an iron supplement. Well, iron supplementation, that's fine, but a common side effect is constipation and upset stomach. That's fine, and typically we grab the script pad again and prescribe an aperion. So 2 drugs already, but we're not treating the underlying cause. The underlying problem is a deficient diet. That's most commonly the case. Rarely we're dealing with an iron absorption problem, so keep that in the back of your mind. But more typically what we do is dietary measures. Traditionally, doctors give the advice, eat more red meat. Hey, beware. Recently, the WHO, International Agency of Research in Cancer, had made an official statement based on numerous studies that meat, red meat, and even worse, processed meat is probably carcinogenic. Heme iron in particular is a potent antioxidant. Moreover, meat eaters are more at risk to develop, for instance, type 2 diabetes. So this recommendation is probably not a very healthy advice. So here you see the publication of the IRC from December 2015. So what we learned in medical school, red meat is your best friend, is no longer the case. Some of you might know that I have a keen interest in nutrition and health, and in my view we should offer a natural remedy if that's available, and prescribing a drug should be the second choice. Well, I know for an iron deficiency anemia we have a very good natural solution with pleasant side effects, and for instance constipation is not the case. Here you see a whole page of plant-based nutrition, so leafy green vegetables, beans, whole grains, and to mention a few, raw nuts, which are rich natural source of the natural iron, the non-heme iron. Be aware that when you add vitamin C, that you stimulate the absorption of high iron, and when you would drink tea at the same time, the opposite will take place. When you have this type of diet, more plant-based diet, you offer your body not only the natural iron, you offer as well vitamins, micronutrients, who pass the placenta very easily, phytonutrients and antioxidants. They play most likely a role in the pathogenesis of, for instance, preeclampsia. And fiber with a pleasant side effect that number 2 is no longer an issue. Other example, vitamin D deficiency, quite common. In Australia, because of this very successful Slip, Slop, Slap campaign, people actually avoid the sun completely. Moreover, we work and live more indoors than in the past. Some women, of course, wear a veil. These are at risk as well. So this is the underlying cause. So why don't we treat the root cause? The natural remedy would be expose your skin to sunlight around noon. Open your solar panels. Of course, more than 20 minutes if you have a darker skin, and of course at all times you should avoid sunburn with the risk of increasing the risk of melanoma, especially if the sunburn takes place when you're a child. If that's not possible, then vitamin D supplementation should be the second choice. Let's continue with the antenatal screening for the pregnant woman. Around 27 to 28 weeks, we nowadays offer an oral glucose tolerance test. Let's zoom in. This is a screening test for gestational diabetes. We know from various research that when we detect gestational diabetes, we treat it appropriately. That results in far better outcomes for the fetus and the mother. So we offer an oral glucose tolerance test. The woman has to fast from midnight. We take early in the morning a fasting venous blood sugar level. We offer her a 75-gram oral glucose drink, and we check the blood sugar levels once more after 1 and 2 hours. So this is a full oral glucose tolerance test. And here are the new criteria, which are much tighter than the ones we used in the past. Fasting, the blood sugar, if it's more than 5.1, and or a 1 hour blood sugar of more than 10.0, and or a 2 hour blood sugar level of more than 8.5, then the diagnosis GDM is made. Do realize that this screening and at the same time diagnostic glucose tolerance test is offered to women who are asymptomatic, who don't have a history. If women, for instance, present with a higher risk for GDM, such as she had GDM in the past, her age is more than 40, she has a BMI equal to or greater than 35, she had previously a baby of more than 4.5 kilos or more than the 90th centile, or she is known with polycystic ovarian syndrome, etc. Those women are offered an early glucose tolerance test to find out that you might have already pre-existing diabetes, if you like. I would like to make a little sidestep here, and it's an important illustration. The so-called hyperglycemia and adverse pregnancy outcome study, beautiful study published in the New England Journal of Medicine in 2008, demonstrated clearly that when we perform a glucose tolerance test, that each of the values, so the fasting, the 1 hour and 2 hour, the lower the blood sugars are, the better the outcomes for the baby. Interesting, as a consequence, only in 2016 we changed from the then used oral glucose challenge test to the now glucose tolerance test. So it took us more than 7 years to implement these changes in our practice, which is quite an amazing time lag. Here, the results of the HAPO study, which involved more than 23,000 pregnant women. In the left panel here we see a graph representing the glucose levels, the category. The blue line presents the fasting glucose, the yellow line the 1 hour value, and the red line the 2 hour glucose tolerance test value. So the higher these values were, the higher the risk that the baby would have a birth weight of more than the 90th percentile. or macrosomic. Same relationship we see with the risk that the delivery will be a primary cesarean section because of macrosomia, and we see as well for the baby higher risk for neonatal hypoglycemia, and particularly when the fasting glucose levels are higher. And when we look at the cord blood serum C-peptide, that's also a clear-cut association, higher blood sugar levels at the GTT, and this marker for the insulin secretion in the newborn is higher. So clear-cut results and impressive results, I must say. So the HAPO study showed if all the blood sugar levels at the GTT were lower, that the baby's birth rate would be significantly lower. And what we saw in the previous chart, there is no obvious threshold value. It's a linear relationship. Hence, we moved away from the oral glucose challenge test to now the glucose tolerance test. Hey, do you realize 7 years time between the evidence in the literature, beautiful study, before we change practice. It takes apparently a long time in medicine to bring about changes, even for the better. It's like the New Year resolutions, you know, a lot of intentions, good intentions, but it's hard to bring about the change. Somebody told me the road to hell is paved with good intentions. Think about it. The last antenatal screening test I would like to present today is the low vaginal swab we offer to women to be taken around the 36 weeks mark. And we screen, we culture for the group B streptococcus. It can be a traditional culture or a nucleic acid amplification PCR technique, which is also very reliable. Here we see a picture how the lady should take the vaginal swab herself, and it's interesting, if we take just a vaginal swab, the predictive value is quite high, both the negative and the positive predictive value. So women who will harbor the GBS at 36 weeks, the vast majority will have the GBS still present in the genital tract, and that's why we want to detect this. If you would combine low vaginal swab with rectal swab, that's even, these predictive values are even higher. So what is the management? If the vagina harbors GBS, which is there without any symptoms to the woman, we administer penicillin G 6 grams during labor. If the woman is allergic to penicillin, we have an alternative, we offer clindamycin. But please check your local antibiotic guideline. And this is done to prevent early onset neonatal GBS sepsis. A little bit more about this GBS screening. About 15 to 25% of all women will be asymptomatic carriers of GBS. And if left untreated, so if we don't give the antibiotic prophylaxis whilst in labor, about 1 in 200 of the neonates will be suffering from the sepsis. And that means, by the way, we have to realize as well, if we do this systematically, we have to check carefully that the pregnant lady herself is not known with an allergy to penicillin, because that might provoke an anaphylactic shock. The incidence of that is estimated to be between 4 in 10,000 to 4 in 100,000. If that occurs in a hospital, that will not have a fatal outcome. But if it occurs elsewhere, you never know. It could have a fatal outcome. And that's why in many countries around the world, and even other states in Australia, they moved away from this screening program for every pregnant lady only to check the vagina for GBS in case of symptoms such as preterm labor, preterm pre-labor rupture of membranes, also known as PPROM, or if the lady has GBS morbidity or mortality in the past, and that means especially her child. Very important, you know, we identify issues, we manage the issues, but now we should carefully document. In South Australia, we still use a hard copy handheld record, but even if you work with an electronic patient record, please document what your plans were. So for instance, document blood group O Rhesus negative. And here it's already indicated make sure that we administer NTD at 28 and 34 weeks, and we check for the existence of antibodies. Another example, if you find out that the lady has iron deficiency anemia, you document it here, and the next person can check and verify whether the diet had a good effect. So, whether the ferritin level has creeped up, or the reticulocytes have increased, showing that the bone marrow is churning away the extra iron, and that the hemoglobin has increased. If not, we might have to move to oral supplementation, and if that would fail, intravenous iron is the way to go. But second and third line in that clear sequence. Diagnosis of diabetes, gestational diabetes, write down GDM and diet. GDM and insulin if that's required. Then it means that your colleague who will see the woman knows what's going on and has not to go through all the notes again. Of course, important when we have the diagnosis of GDM, we have to follow it up with an oral glucose tolerance test 6 to 8 weeks postnatally, because that GTT should be normal. If not, we're dealing with pre-existing diabetes. Good. This is the summary then. This is the last slide of the antenatal screening for pregnant women. We discussed item 1, 4 and 5 because they're dealing with the mother-to-be. Conclusion, request all screening tests for the pregnant woman after the initial visit, and there might be variations in other countries and other parts of Australia, but check your local guidelines, check the results and manage these issues as quickly as possible because that contributes to better outcome. For instance, a profound iron deficiency anemia is associated with growth restriction of the baby. Explain and motivate the pregnant woman to be compliant, and it's remarkable because pregnant ladies have an extra motive, that's the maternal altruism. So grasp that opportunity, so to speak. Document all the issues you identified and write down what your plans were, how you are going to manage various issues. It's essential in contemporary practice that we not only identify, manage, but also document the issues, because we're passing on the baton to another colleague, and it's paramount if that colleague wants to continue to run that you do all 3 the above. That concludes the first part of the trilogy antenatal screening in pregnancy. I thank you for your attention, and in the next video we will discuss screening for trisomia 21 and 18. In the third one we will discuss gross congenital malformation as can be found when we do a morphology scan. Thank you.